Hi, my name is Areza. My group members, Rachel, Connie, and I will be discussing conflict resolution in the workplace. I will begin with a situation followed by some dialogue where conflict can be visualized. I will then talk about the stages of conflict, negotiation, define our resolution strategy, and then some destructive techniques as well. Patient A sends his patient Miss B over to labor and delivery for a scheduled induction at 39 weeks gestation due to high blood pressures in the office the week prior. Miss B desires a vaginal delivery. Nurse C reviews Miss B's records and begins the admission process. Nurse C notices that her blood pressures have been normal throughout her pregnancy and is currently 110/70, urine dip was negative. The induction process was started according to physician A's orders. When Miss B got to 12 milliunits per minute of Pitocin, she started contracting 6 in 10 minutes and had a run of late decelerations. So Nurse C backed down the pit. Later, the fetal heart rate tracing was reactive and her blood pressure was still 120/70. However, Nurse C could not increase the pit due to prioritizing her other patient with a bad tracing. Physician A arrives back on the unit to check on Miss B's progress and feels that Nurse C is dragging her heels. Physician A approaches Nurse C. Nurse: Dr. A, I'm not really comfortable increasing the pit. Miss B had tachysystole with late decelerations when she was at 12 milliunits a minute before. What's the urgency? Physician: Nurse C, I'm worried about the tachysystole too, but there haven't been any more decelerations, so I think we're okay. We need to have this baby. I don't want her getting choreo. Please go up on the pit. Nurse: Can I have an IUPC then? Physician: You seem more worried about the oxytocin dose than I am. Is there something else going on? Nurse: Honestly, Dr. A, I'm wondering why we even induced her in the first place. I haven't seen a single elevated pressure, and I'm frustrated that we've committed the patient, and now more pit is going to land her cesarean when she really wants a vaginal birth. Physician: Okay, I see. You're right. She hasn't had any elevated pressures here, but she did in the office. And I had a patient who had a stillbirth at term with gestational hypertension once. So I don't want to take any chances. I'm worried that if we don't increase the pit, she'll get infected and need a section. I'm going to be in-house, so how about you increase the pit regularly, but call me right away if you're concerned about the urine activity or fetal heart rate. Nurse: Thanks, Dr. A. It's funny we're both worried about her having a section for different reasons. I'll increase the pit every half hour and I'll call you to review the tracing if I have any concerns. The 5 stages of conflict. Latent conflict is antecedent conditions. For example, in this scenario, the nurse had another labor patient to care for. Acuity might have been high, or maybe staffing was short. The next stage is perceived conflict, when it is intellectualized. Fortunately for us, our scenario stops here, as both the nurse and physician communicated their logics and came up with a plan to collaborate care for the laboring patient. If phases were to continue, we'd go on to felt conflict, which is emotionalized, manifest conflict, action taken, whether it is to withdraw, compete, debate, or seek conflict, and then conflict aftermath, positive or negative. In our case, it was positive. So in terms of negotiation, we're going to discuss before, during, and after. Before, be prepared mentally by having done your homework. Determine the incentive of the person you're negotiating with. Determine starting points, trade-offs, the bottom line, and look for hidden agendas. In this scenario, Nurse C did do her homework. She reviewed the chart and noticed that there were no histories of high blood pressure recordings. She inquired as to why Miss B's induction was so urgent and decided bottom line she wanted to prioritize patient safety and advocate for the patient's wish of a vaginal delivery as much as possible. During, you want to maintain composure, ask for what you want assertively, role model good communication skills, be patient, take a break if either party becomes angry or tired, and avoid destructive negotiation techniques. Nurse C approached Physician A with her concerns, using clear communication skills and asking for a rationale behind the order. She also allowed for Physician A to speak and express his own concerns, and both avoided any destructive negotiation techniques, which we will discuss. After, you want to reinstate what was agreed in verbal and in writing, recognize and thank all participants. Both the nurse and the physician restated what was agreed on. They acknowledged the rightness of both sides and thanked each other for a collaborative solution. As far as resolution strategy, you can see very clearly they use collaboration. So collaborating is the assertive and cooperative means of conflict resolution that results in a win-win situation, which is what is demonstrated here. The 3 destructive techniques I decided to include was ridicule, which is a tactic with the goal of intimidating others involved in negotiation. Ambiguous or inappropriate questioning, it's a tactic with the goal of diverting the issue or changing the subject. And then flattery, which is a manipulative tactic in hopes of increasing the chance for a person to side.
So I'm Rachel, and I'm going to be talking to you about delegation. So our situation with delegation, so we have an RN, and she delegates to the CNA to transport patient X out to the front entrance of the hospital. The RN communicates with the CNA and lets them know, hey, the patient is ready for discharge. They already have discharge instructions. I just need to take out the IV first before you transport patient X out to the front entrance of the hospital. The CNA goes ahead and transports the patient out to the front entrance of the hospital. The RN returns to the patient room to go ahead and take out the IV, and then RN notices that the patient is gone and the IV hasn't been removed yet. RN hurries up, runs to the front entrance of the hospital, and thankfully is able to take out the IV as the patient was just about to get into their car and leave and go home. So let's review just a few things that may have gone wrong in this situation when we look at our 5 rights of delegation. So when we review the 5 rights of delegation and compare it with our scenario, first we want to look at the right task. So was this situation the correct task? Could this task be delegated to the CNA? So in this situation, it was the correct task. This, as defined. So this refers to the task that's being delegated and ensuring the task can be delegated. So like I said, a CNA is capable of transporting a patient in a wheelchair out to the front entrance of the hospital. When we look at the circumstance, so typically, you want, as the RN, you want to be asking the question to yourself, is there appropriate equipment available to perform the task? Does the delegatee, have the right supervision to accomplish the task? Is the environment favorable? So in this scenario, I really don't see that there was any issues with the circumstance. So there was a wheelchair available, the environment was favorable, there was no obstacles as far as that goes, and of course, as we already stated, the CNA was able and capable of transporting the patient to the front entrance of the hospital. When we look at the right person, so the CNA was the right person to be able to delegate this task to. The CNA does not require any supervision with transporting a discharged patient out to the front entrance of the hospital. And then the mode of communication / direction. So the RN could have been more clear when communicating and delegating to the CNA. So the RN gave the instructions, but she did not wait for the feedback from the CNA to know for sure that the CNA understood and heard what the direction was. And specifically, that's regarding, hey, I'm going to wait to take this patient out before, until you take out this IV. So we know that the RN communicated that to the CNA, but what we don't know is, did the CNA hear exactly what the RN communicated? and did they receive that information? So in this situation, the breakdown in the 5 rights was with the feedback in number 5. So the orange should have made sure that the CNA gave her feedback to let her know, hey, I heard you. I'm going to wait to take this patient out to the front entrance until you remove the IV. If the nurse had waited for that feedback, it probably could have prevented the CNA from, taking out the patient too early. And CNA probably, would have stayed there and waited until the nurse did what she needed to do with the IV. Lastly, we're going to talk about some delegation errors. So none of these 3 errors really happened in our situation that we discussed as far as delegation goes. But these are important errors and should be noted. So over-delegation refers to basically giving too many tasks at one time. Some managers, they can be over-delegators and can be habitual offenders of this delegation error. They don't monitor their time wisely, and they spend, a good portion of their time just trying to get organized. And they spend too much time getting organized and not enough time actually completing the tasks. Then we have improper delegation. So it includes, as it implies, so incorrect time, incorrect person, incorrect communication, feedback. It could be anything that goes wrong with one of those 5 rights. So hence improper delegation. And then we have upward delegation. So this is where a subordinate actually delegates up the ladder to make use of their manager to get the manager to complete a task. So of course, in the 5 rights of delegation, this would be an error because the delegation comes from an authoritarian and has to be delegated a task that can be delegated below them.
My name is Connie, and I'll be talking about creating a healthy work environment. The definition of a healthy work environment is one that is safe, empowering, satisfying, healthy, and secure with a sense of physical, mental, and social well-being. The components of a healthy work environment include open communication, a relaxed environment, compassion, respect, and understanding. My present work environment, I would have to describe it as being one that is healthy. The environment feels safe and open to new ideas and suggestions to make our jobs more efficient. There's a unity of teamwork and a sense of overall safety. The steps to creating a healthy work environment would include to ensure that those lines of communication are open and feel comfortable going to supervisors and leaders and expressing your ideas, being supportive of staff, and providing encouragement. What must an effective leader do to create a healthy work environment? Of course, they must help to ensure safety at work, make sure there's different protocols, and have access to security when needed. They need to empower the staff, make them feel like families, and make them feel like a unity, and support each of the staff members and their ideas, and also leave those lines of communication open and provide encouragement, and of course be a role model for those that you are leading.